Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
Dr. Cothren Burlew is a trauma surgeon in Denver, Colorado. She is world-renowned for her work on pelvic packing, as well as blunt cerebrovascular injuries, among many other things. We caught up with her to find out how she managed to do so much and have such a productive career, and specifically to also talk to us about pelvic packing and blunt cerebrovascular injury.
Well, for all of our listeners, it's an absolute pleasure to have Dr. Cothren on the podcast today. Dr. Cothren is a remarkable human being, both in terms of work life as well as personal life, and I hope we get to explore some of those things in the next few minutes. Dr. Cothren, welcome. Thank you for being on the podcast. And for some of the listeners across Canada in particular who may not know you as well as we do, can you tell us about where you grew up and what your training pathway was?
Absolutely, and thank you so much, Chad, for having me. It's really an honor. As you know, this is one of my first forays into the podcast realm. So yes, hopefully this will translate well. So, I grew up in Texas. I grew up in San Antonio. I went to the East Coast for college, returned back to Dallas for medical school, and then did my training and fellowship here in Denver, and then have been on faculty here in Denver for almost 20 years. So that's what it is. In a nutshell, is a little bit of my training pathway.
Wow, time flies, eh?
It does. It does.
Really does.
Thankfully, and sometimes not so thankfully.
Yeah, exactly. You know, a lot of us, not just me, have admired your career and your contributions, not only to clinical medicine, but to the research side of it as well. I was wondering if you could tell our listeners what sort of prompted you to be so prolific and so thoughtful in terms of research on the one side and really continuing medical education on the other.
You know, I think, when I have been fortunate to give talks and particularly to talk to medical students and residents, one of the things I always try to emphasize is that you as a single individual can really make an impact upon the care of for me, the injured patient or for any patient. And I think that the ability in surgical research to pose a question and to develop a hypothesis and rigorously test it, and to actually answer that question and to really alter how we manage patients for the better is really one of, I think, the most incredible things that we can do as surgeons, as educators, and as scientists. And I think that's really what has driven me. Once you have the bug and you figure out that you can really answer questions that you don't know how to take care of something, that just begets, more inquiry. So it always seems that you answer one question and then you get three others.
Yeah, that's well stated. It seems like there's no end to the voyage anytime soon. There's no doubt.
So true.
Yeah, your productivity, obviously, as we sort of dance around it here, but I'll just state it is really, really impressive and something we all try and emulate. You are a busy mom. You have a busy family. You have an incredibly busy practice with a lot of demands. And then there's the academic side of it, and of course your administrative side. I'm curious, how do you balance that, and how do you remain so impressively productive just overall? What are some of your tricks?
Well, I think one of the things that I encourage younger surgeons, both men and women, and maybe particularly for women. The first thing that I do is I throw the word balance out the window, because I think that trying to quote unquote attain balance means that you're trying to accomplish something. And the minute you have imbalance means that you failed at something. And so for me, I really have tried to have focus. And really it's a matter of where is my focus at the current moment. And some days I have more focus on my academic and clinical life, and other days I have more focus on my family and my home life. I think, any busy working mom learns how to delegate. We learned that you try to outsource everything humanly possible. I joke with my husband that we're stimulating the economy because we have a cleaning service, a dog walker, a yard person. We have a spectacular nanny. We have so many people that help us, allow us to do our jobs very effectively, and then to really focus on our family. And so I think having that infrastructure of help enables me to be really good at my job and hopefully really good as a family member, as a wife, and as a mom. And so I think those sort of mental adjustments have been really important to me. And then I think that the other key to success in being, sort of by the historic measures of productivity, whether it's book chapters or articles published or presentations given, is that you have to be really interested in what you're doing. And I have been fortunate to fall into a couple of different areas that really have piqued my interest. I'm fascinated in how we manage patients in those particular areas, whether it's open abdomen management or pelvic fracture management or ED thoracotomy or BCVI. Sort of have a couple of arenas that really have interested me. And then, once you have that interest, it's really easy to keep foraying and trying to figure out new and better ways to take care of patients. So hopefully that it's a compendium of thoughts, but hopefully that helps delineate a little bit of the juggling.
Yeah, as usual, that's so well said, and I'm so happy to hear you talk about the term balance in that way, because on this podcast and in real life around the hospital here with our trainees, I often challenge the use of that word, both locally as well as in greater society. And I think words like that you've used, like passion, in particular, are probably more important for a lot of us than the traditional notion of balance. Since you brought it up, and in particular, I think it would be helpful for maybe some of our community general surgical crew across a very large geographically dispersed population and country here to maybe delve into a little bit about pelvic fractures and management of that in general. It's of course fine when, super trauma surgeons like yourself or hopefully maybe at the Foothills Hospital here when we have all the toys and the hybrid ORs and all these different things. But what would you recommend for the really critically ill patient that maybe can't have an immediate transfer out from a more rural location in terms of management of that pelvic fractures? How do you frame that? And maybe beyond that, you could describe or at least frame the concept of preperitoneal packing in particular.
Yeah, so obviously I have an interest in pelvic fracture management, and our group have been some of the early people to push the idea of pelvic packing for trauma. And I think for those that are in the rural setting or in in an area in which you may not have angiography, pelvic packing is a perfect way to address pelvic fracture related hemorrhage. So when I talk about pelvic trauma as a whole, I remind people that the vast majority of patients that have pelvic trauma don't need an intervention. They don't need angiography even, or they don't need pelvic packing. And so it's really a very small proportion, about maybe at most 10% of all pelvic fracture patients that need an intervention for bleeding. And so when you really cull down those numbers and then look at those patients, we use our intervention point for pelvic fracture related bleeding. And whether you choose to do pelvic packing, which is what I would advocate, others still do angiography, our intervention point is the same for both of those groups. And so for us, if patients remain hemodynamically unstable despite getting 2 units of blood, those are the patients that have ongoing bleeding that need an intervention. So it's not based upon their CAT scan finding. It's not based upon that blush on your 64 slice CT scanner that probably doesn't mean much. It's really based upon the patient physiology. And so even if you are in an area where you can't, take a patient to angiography, you can take them for pelvic packing. And so using those simple techniques of binding, whether you use pelvic sheeting or you use a binder in order to stabilize the bony pelvis, prevent ongoing shifting of the bony elements. You do massive resuscitation with 1-to-1 ratios of doing hemostatic resuscitation. And then in those patients that don't stabilize, those are the patients that really go on for pelvic packing. And that can be done anywhere. And we've even, we get a fair number of transfers here. We've talked surgeons through the procedure at outside facilities that really, are level 3 trauma centers that don't have the resources of a level 1 center. So I think pelvic packing is absolutely something that should be in the armamentarium of any surgeon.
I couldn't agree with you more. And we've seen it used as well in some pretty remote locations by some pretty, inexperienced surgeons is the wrong term, because of course they're very experienced, but maybe not super high volume trauma exposures at any point in their training or their practice. I was wondering if you could maybe just very briefly walk us through those steps in terms of preperitoneal packing. And of course, for the listeners, we'll link your papers and the Denver papers on this as well. But just to get us started and give us a sense of what's involved.
Yeah, absolutely. And it, several years ago, 2 or 3 years ago, I was asked to give a video session actually at East. And so you can actually look, Journal of Trauma has a link to that video session in case you want to see sort of real time what it looks like. I think the key thing to remember is that pelvic packing is asking you to do exactly what you've been told your whole career not to do, which is to go and touch the pelvic hematoma, right? We're always told, don't unroof a pelvic hematoma, don't jump in there. And now I'm telling you, go jump right in there. I think the important thing to keep in mind as you talk about pelvic packing is, number one, if you have an orthopod who can put an external fixator on, I think that is a critical component to stabilize the bony pelvis so that you really have a stable framework into which you place your packs. If not, then it's perfectly fine to keep your pelvic sheet on. It's going to be down on your greater trophanters, and you'll be able to get to the suprapubic space without an issue. But my first vote would be to try to have your orthopod put an external fixator on. Barring that, I would still go ahead with pelvic packing. What you simply do, you make about a 6 to 8 centimeter incision. You start at the symphysis and proceed cephalad. You just sharply go down and then use a bovie to go down through the subq and the fascia. As soon as you go through that posterior fascia, you pop into that preperitoneal, but it's also really this paravesical space. So if you think of the bladder as a central midline structure, it's an inverted U around the bladder, and it actually extends from the backside of the symphysis down into that sort of paravesical space all the way down posteriorly. So if you think of it as an inverted U around the bladder, that sort of helps you visualize what that space is going to look like. Moreover, the pelvic hematoma from the pelvic fracture actually dissects that entire space. So once you sort of place your hand in there and push down on the bladder, typically that's when the pelvic hematoma will start to egress out of that space. I put my hand around the bladder, pull the bladder to one side. So if I'm packing the right hemipelvis, I put my left hand in. I'm standing on the patient's left side, put my left hand in, pull the bladder over to my side. And then I use a ring forceps for my first lap pad, put it all the way down posteriorly. And then you pack in another 2 pads up around the side of the bladder. And then you repeat the entire thing on the opposite side. So usually you get 5 to 7 laparotomy pads in, but usually it's about 6 pads with 3 on each side. And then I simply run the fascia closed with a running PDF suture and then put some skin staples in. It really is not challenging. And I think that's been the hardest thing in the last 15 years in talking about this technique. It's not that hard to do. I think it is scary for individuals because we've been told not to go into that space or to unroof the hematoma. But as long as you keep it in that confined suprapubic incision, you're not egressing that pelvic hematoma into the abdomen. It's when you do a trans-abdominal exploration of the pelvic hematoma that I think you get into trouble. So if you stay in that preperitoneal space, pack it off, then those patients will stabilize for you. And it's not that hard.
Yeah, that's a brilliant description. I totally agree. And your last point, I think, it just to emphasize it again, is really salient, that this is a different procedure from diving into a large pelvic hematoma that's contained from the top via laparotomy, and they should be separate and distinct.
Absolutely. And keeping those incisions separate is really critical. If you allow those incisions, if you have to do a laparotomy, say you have to pack the liver or you need to do a splenectomy, you need to do that through a supraumbilical separate incision. And your pelvic packing incision is way down low right next to your pubic symphysis. Occasionally, a patient comes in, they're hemodynamically unstable, we do a fast exam and it's positive, so we whisk them up to the operating room, we do the splenectomy, we pack the liver, we take out the bowel, whatever needs to be done. And then you look down and they still have this big pelvic hematoma. If the patient's unstable, then they also need pelvic packing. If they're stable, they may not need an intervention for that pelvic hematoma. But if they're unstable in the OR and you see that pelvic hematoma, the key then is to come back out of the abdomen and do a separate incision for pelvic packing. I totally agree.
One of the other things that I've seen you answer on a number of your talks around the world is the efficacy of packing, more specifically with regard to anatomy. And I've seen people ask you the question, they sort of framed it by saying it makes a sort of intuitive sense that you can pack venous hemorrhage through this preperitoneal space, but can you really pack arterial hemorrhage as well, which of course is the driver for a lot of our persistently hypotensive bad pelvic fractures. What are your thoughts on that?
You absolutely can. So that's the simple answer. So yes, the whole reason we adopted pelvic packing was because 85% of bleeding is due to venous and bony elements. So we thought, why not go address that preponderance of bleeding sources? But there still is about 10 to 15% of bleeding sources that's arterial. The great thing about pelvic packing is once you pack that pelvis, I would say upwards of 95% of patients stabilize. And even if they end up needing to go for angiography and angioembolization, which in our now almost 2 decades of experience, about 9 to 13% of patients have ongoing bleeding once they're in the ICU, and they go and they actually have an identified arterial bleed that needs an embolization. The nice thing is, by packing the patient, you actually temporize them. You can take them to the ICU, you can resuscitate them, you can correct their coagulopathy, you can address, obviously, if they have other injuries, if you need to scan them, if you need monitors. You can do lots of other things, but you'll temporize that pelvic fracture bleeding, and it enables you to figure out which are the 10 to 13% of patients that need to take the trip for angiography or need that invasive additional step, because the vast majority, 90% of patients, don't need to have embolization done.
Yeah, absolutely. I want to shift gears here just a little bit and ask you about potential interactions with REBOA, which of course, has been a hot topic now for a number of years and probably very overstated. In general, I think probably more sizzle than steak. But having said that, where does REBOA fit into your algorithm for persistently hypotensive pelvic fracture patients, or does it at all?
Yeah, so I agree with you. REBOA has been quite the topic of conversation for several years now. I was very skeptical, I have to admit, skeptical of REBOA when it first came out. I'll just admit my bias. And for me, I really have, I don't use it for everybody, but I feel that there are definitely patients that are now walking around out there that would not be out walking around without that REBOA in addition to their pelvic packing. So for me, the way that we've incorporated it into our algorithm is we initiated it, and we presented our data just at the AAST this past September. We initiated it back in 2015, if I recall correctly, 2016, and we did it in a very careful, stepwise manner. We incorporated it that if a patient had a persistent systolic pressure less than 80, that those patients would be considered for REBOA by the individual practitioner. And as we all recognize, there are patients that have a single systolic of 75 and then they bounce back up to 90, then back to 82, and then back up to 100. Those maybe aren't the patients that need REBOA. But the patient for me that needs a REBOA is a patient who has a systolic of 55, and they are not budging from 55, 60, they're peri-arrest. It's amazing if you put that catheter in, the sheath in, the catheter in, And I only put it in zone 3. I feel that's the safest thing for me to do. It's amazing that their blood pressure pops back up to 90 to 100. It stabilizes them. It gets them upstairs. We pack them. We get the balloon down, and we get the sheath out. So for me, literally from start to finish, from the moment they hit the ED, and we can go through the entire process, Reboa downstairs, upstairs, pelvic packing, sheath out, and it's about an hour total from start to finish. So to sort of sum up, for me, the Reboa, I tend to use it if they have persistent systolic less than 80 and probably less than 70, despite getting massive transfusion. And it's really a bridge to get them to the operating room for pelvic packing.
Yeah, that's absolutely a beautiful way to frame it and to use it if you have those skill sets. There's no doubt. I want to switch gears once again here to a final clinical topic with you. Yeah, and that's touch on BCVI or blunt cerebrovascular injuries for our listeners that don't deal with them on a daily basis. And obviously, very much like pelvic fractures, you and the Denver group have become extremely well known and sort of industry leaders, so to speak, with this topic. So I'm curious, in particular, if you could define a BCVI for our listeners, number one. Number two, tell us about who you're screening in 2020, in particular, number two.
Yeah, great question. So, BCVIs have been recognized, really probably recognized since the 90s, I would say. And we've become much more adept at identifying them and treating them, I think, in the last probably 10 to 15 years. We have a standard classification system. Grade 1 and 2 injuries are dissections with relative narrowing of the artery. Grade 3 is a pseudoaneurysm. Grade 4 is an occlusion, and rarely do you get a transection, which would be a grade 5 injury. But the vast majority are graded 1 through 4. And the reason that we grade them is not only so that we have an easy taxonomy, a way to talk about it, but that in general, the risk of stroke is related to the grade of injury. And so I think as we are determining who should be treated and how quickly, particularly in relation to other injuries, the risk of stroke, I think, goes into that conversation so that you can risk-benefit the risk of bleeding related to treatment, which is some type of antithrombotic, either antiplatelet or systemic heparin, versus the risk of stroke related to how many injured vessels you have and what grade of injury those are. As far as how do we figure out that the patient has an injury, who do we screen? We still obviously have a Denver screening criteria. We've published that. We most recently updated it a couple of years ago, and it's called the Expanded Denver Criteria. And I think that the key, the Expanded Denver Criteria has a big laundry list of different specific injuries. But I think in addition to that you really have to think about the mechanism of injury. And so one of the top line of the expanded criteria says that it's injury mechanism. The reason that we like to use those two things in combination is that you could have a very low injury mechanism, a fall from standing. And we've seen this particularly, several groups have published in the geriatric population of late, that fall from standing is a significant mechanism, but those patients also have one of those identified injury patterns that are associated with BCVI. So for us, it's a combination both of the mechanism and of the specific associated injuries that go along with it.
That's beautifully stated as usual, and I think really the expanded Denver criteria that you talk about and that we'll link to the podcast really have become the industry standard throughout the world, and so we no doubt thank you for that. How does the synchronous or the concurrent, moderate to severe traumatic brain injury impact our ability to treat these patients? And what are some of the innovative things that you guys are doing, whether it's monitoring or critical care or treatment, to try and help look after some of these really, really tough scenarios?
Yeah, I think you have absolutely hit on the crux of one of the hardest clinical conundrums. I think many of us who treat BCVI patients, say with a solid organ injury or even with a pelvic fracture, I am much more likely to put a patient who has pelvic packing in place, of just halted pelvic fracture-related bleeding. I'll put them on a heparin drip for, if they have a grade 3 and a grade 4 BCVI, because I'm so worried about stroke in that patient. Mm-hmm. Same probably true for solid organs. I'm much more likely to start those patients on a low-dose heparin drip. A TBI is a much more difficult question and answer. And I don't think any of us really have a great set of guidelines. If you look at the literature to date, most institutions don't start some type of treatment until at least 48 hours and sometimes 72 hours after identification of the injury and a stable head CT. So when you look at the literature in TBI patients with associated BCVI, you really have to look at the timing of initiation of the treatment. You can start treatment, but the timing really, I think, is critical, and a discussion with your neurosurgery colleagues is part of that. For us, I think our neurosurgeons get tired of us asking every single day for permission to start a heparin drip, and so one of our goals actually in the coming years is to describe our current experience as far as which TBIs are more likely to bleed, which ones are higher risk, which ones are we willing to start heparin drips on sooner, and hopefully that'll help delineate some of these care questions, because I agree that it's just the misstep is can be tragic if you start that anticoagulation too soon.
Well, that kind of nuanced contribution to the injury community would be unbelievable. So I hope that's successful. I guess thank you very much on behalf of all of us for a 30,000 foot and even more granular than that masterclass on pelvic fractures and blunt cerebrovascular injuries. Can't thank you enough. I wanted to ask two questions in closing and bring us back out, if that's okay. The first is that. Sure. You are relatively active on social media platforms, and I'm curious how you frame that as an academic surgeon, how you use it, how you maybe think it shouldn't be used briefly, and how it's been helpful for you in particular. And the last question that I'd love you to comment on, and we ask a lot of our guests, is that if you were to go back to being a trainee or maybe starting out your career, what piece of advice would you give yourself at that time?
Oh, two. Okay, I'm gonna start with the easy question. You're kind in saying that I'm active on Twitter, which accounts for. I could be more active. Maybe that's the best way to put it. So I owe Lily Lau several years ago when I was president of the Southwestern Surgical, convinced me that I needed to get onto Twitter because it was a terrific way to connect with other surgical colleagues. And it's funny, she actually took the picture that still is on my profile. She took of me in the lobby of the hotel at that meeting, and I leave it up because it reminds me of the instigating point that I actually got onto Twitter. Yeah. And I think that I've tried to follow a little bit in Lily's footstep, or Ronnie Stewart, or my current partner Jamie Coleman. I think that for me, Twitter is I stick only to. Occasionally someone posts a funny, COVID-related saying that I have to think is hysterical, but I really stick to scientific items in there, whether it's to promote something within a surgical organization that I'm a member of, if the AAST has something happening, or Southwestern Surgical. And then I also think that it's a great way to have conversations about clinical conundrums. And to me, it's fascinating to see so many different perspectives about the way that we manage the injured patient. And so I think being active on Twitter, for me, I am almost more of an active observer, because it provides me with such an insight into how people manage patients differently across the country and the world. And I think that has been really eye-opening. I think we all recognize that we are a product of where we train and who our partners are and what the latest meeting is that we went to. And so I think it's a terrific way to get new and different ideas out there. And so it's kind of fun to see different people sparring about how we should be doing things. So that's my take on Twitter. And I have to say that's the only social media of which I ascribe intermittently to. As far as what would I tell my younger self?
Yeah.
That is That is so interesting. Maybe interesting is not the right word, because, on any given day, I think that I am my younger self and not my older self. So I think that probably, so many people are being asked as residents, where do you see yourself in 10 or 15 years? I would say that I didn't have a great plan, which maybe doesn't sound particularly inspiring, but I do think it's important that in some ways not having a master plan helps open up opportunity. And so for me, I think it really was allow yourself to see the opportunity, allow yourself to become interested in things that you want to do and pursue those. And that you don't always have to adopt the things that your mentor wants you to do or the interests that someone else wants. And so I think, rather than projecting where you might be in 10 or 20 or 30 years, I think taking advantage of the daily opportunity and seeing the possibility in that, I think is really important.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurg. Thanks again.